Good morning, everybody. Good morning, good afternoon, good evening, depending where you're listening to this lecture. This is the lecture on alcohol and cancer. Alcohol and cancer is an old story, and I will tell you why. Now let's start with the alcohol attributable fractions for selected causes of death. And you can see if you look at alcohol use disorders and fetal alcohol syndrome, 100% is due to alcohol. If you look to liver cirrhosis, 50% of all liver cirrhosis is due to alcohol, the rest not. And if we have a closer look to the cancer situation, then oral cavity and pharyngeal cancer is 30%. A third is due to alcohol. Laryngeal cancer, also high number, is due to alcohol. And if you look at esophageal cancer here, it's also 22%. If you go further down, we see liver cancer 12%, we see colorectal cancer 10%, and breast cancer. And we remember that especially colorectal cancer and breast cancer are very, very frequent cancers in the Western world. Now, alcohol and cancer, as I said, is an old story, and that was primarily for the first time discovered by French pathologists in 1910. And this is a classical painting from Edgar Degas from the French school, and shows absinthe drinking in those days together with smoking, which is a very bad combination. Now, the NIH had a first alcohol and cancer workshop in 1978, and I had the privilege to be invited to that workshop. And since then, NIH continued that for several years, and also other special meetings on alcohol and cancer took place. Now, in 2007, the International Agency on Research on Cancer in Lyon gathered quite a number of specialists, and after 10 days we came to a conclusion on this topic. And the conclusion was published in the Lancet Oncology, and it says alcoholic beverages are carcinogenic to humans. The occurrence of malignant tumors of the oral cavity, pharynx, larynx, esophagus, liver, colorectal, and female breast is causally related to alcohol consumption. There is substantial mechanistic evidence in humans deficient in aldehyde dehydrogenase that acetaldehyde derived from ethanol metabolism causes malignant esophageal tumors. Now, worldwide, alcohol-related cancer deaths in 2016 is shown here. And you see that especially for the oral cavity, a quarter of all is due to alcohol. For the pharynx too, and the larynx. So this is the upper aerodigestive tract cancer, where alcohol comes directly into contact with the mucosa. But also 3 very frequent cancers like the colorectal cancer, the liver cancer, and breast cancer, alcohol plays an eminent role. And in 2012, the total number of alcohol attributable cancer cases increased to 5.5%. Now, the percentage of alcohol-related cancer cases is shown here. So if you look at this, it's altogether 100%. And of this 100%, especially esophagus, colorectal, and liver cancer contribute much to this 100%. So this is how alcohol contributes to these cancers. Now, if you look at the different cancer sites, there is a relationship between alcohol consumption and cancer risk is monotonic, and there is no threshold, and I think that's very important. The higher the amount of alcohol consumed, the higher the risk of cancer development. You can see here mouth and oropharynx cancer, esophageal cancer, larynx cancer, and these are steep curves which especially are important when huge amounts or higher amounts of alcohol are consumed. That means especially in the alcohol-dependent patient. If you look at the lower part of the gastrointestinal tract, there are colon cancer, rectal cancer, there is also liver cancer here. Any reduction, and there is good data on that, any reduction in alcohol consumption has a beneficial effect on reducing cancer risk. The slopes here are not as steep, but again, these are high cancer which occur very frequently in the Western world, so alcohol has an important input here, especially not only on colon and rectal cancer, but also on colon and rectal polyps. With respect to breast cancer, there is also no threshold. And you may say the risk is not so high, it goes up to twofold, but 2 is not as high. But again, breast cancer is very frequent, #1 cancer for women in our country and in other countries too. So one has to consider alcohol as a very important risk factor. Alcohol-related cancer death rates are higher than death rates for alcoholic liver disease, at least in 2016. Now, these are epidemiology data. That epidemiology has to be proven by experiments and by basic research. And these are 4 studies with different type of mice and with Spork Dolerates, where alcohol is given in the drinking water and is given for a long time, 104 weeks, lifelong, for a long time rather. And we see that for the hepatocellular adenoma and carcinoma, more male animals develop that under alcohol as compared to non-alcohol. For the papillary and medullary adenocarcinoma of the breast, the same is true, and no tumors in the control groups. And for the intestinal tumors, the APC min mouse was used, a genetic model, and we see with alcohol more intestinal tumors, more in the distal side. And finally, in Spork Dolerates, there is more tumors when they receive alcohol lifelong in the oral cavity, lips, tongues, and forestomach. Without giving any procarcinogen or carcinogen, this is just alcohol alone, so alcohol is a carcinogen. Now, it's not only the amount of alcohol and the time span alcohol is given, there are other factors. And individual risk factors play a role. The risk of developing certain types of cancer associated with chronic alcohol consumption is modified by individual factors, which vary inter-individually and consist, among other things, of genetic, lifestyle factors, such as smoking, nutrition, simultaneous exposure to certain xenobiotics, and pre-existing diseases. Now, before we go into mechanisms, I want to show you a metabolic pathway, very simplified, for alcohol. Alcohol leads to inflammation, and alcohol leads to induction of cytochrome P450-2E1, which is important for its own metabolism to acetaldehyde. And this CYP2E1 then may lead to reactive oxygen species with a number of negative effects, binding to protein with neoantigens, but also leading to lipid peroxidation with lipid peroxidation products such as 4-hydroxynonenal and malondialdehyde, and these both factors bind to a DNA basis, generating exocyclic Etheno-DNA-Adducts, which are very carcinogenic. This is one side of the coin. The other side is that alcohol is metabolized by alcohol dehydrogenase primarily to acetaldehyde, which is also a carcinogen and leads to various negative effects. So let's have a closer look to both factors. Risk factors in alcohol-associated carcinogenesis is heavy alcohol consumption. Of course, as I said before, more you drink, as higher the risk, but it's also smoking. Now, these are a wonderful old study from Albertans from France, showing esophageal cancer risk. If an individual smokes 30 cigarettes or more per day, there is a risk of about 5. If they drink alcohol 120 grams per day, there is a risk of about 50. But if they do both, if they smoke heavily and drink heavily, there is a non-saturable synergistic effect of more than 100 or even 150. This is a very high risk for that combination. Why? One is that acetaldehyde is coming in from cigarette smoking. With each cigarette, you bring in acetaldehyde. This is diluted in saliva, and you can see that here from the Finnish group of Dr. Salasporo, we have much more acetaldehyde in the saliva. And in addition, if a smoker drinks alcohol, the conversion of ethanol by oropharyngeal bacteria is much higher as a non-smoker. So there is more acetaldehyde in the saliva after alcohol consumption in the smoker. Smoking changes oral bacteria in quality and quantity. Now, I summarize that here. Tobacco smoke contains a variety of procarcinogens and carcinogens. Some of these procarcinogens, especially nitrosamines and polycyclic hydrocarbons, are activated to their alternative metabolites by ethanol-induced cytochrome P452E1 in the mucosa of the oropharynx. Tobacco smoke contains acetaldehyde, and tobacco smoke increases the number of oropharyngeal bacteria which convert ethanol to acetaldehyde. Now the risk factors continue with genetics and poor dental status, and this has also something to do with acetaldehyde. Acetaldehyde, carcinogenicity, and genetics. Now, first of all, acetaldehyde is a carcinogen. It leads to cellular damage, inflammation, metaplasia, and hyperregeneration. It has genetic and non-genetic effects. The genetic effects consist of chromosomal aberrations, sister chromatide exchanges and point mutations, and finally DNA-adduct formation. The non-genetic effects are inhibition of DNA repair and a weakening of the antioxidative defense system. And finally, a disturbed methyl transfer. Now, as I said, acetaldehyde binds to DNA, and there are two major adducts. This is an ethyl desoxyguanosine, which is not carcinogenic, which is a marker for alcohol consumption. The other one, the propranodesoxyguanosine, is highly carcinogenic, and it's produced in the presence of basic amino acids, histones, and polyamines. And we know polyamines are the trigger of hyperregeneration. If you have a hyperregenerative tissue, which is by itself prone to disturbances, to attacks with respect to cancer, then you form these carcinogenic attacks. So you have really a milieu, you have an environment which opens the door for carcinogenesis. Now, if alcohol is metabolized to acetaldehyde, first of all, bacteria play a role. I would point that out in the next slide, the role of bacteria. The Finnish group of Dr. Salaspuro has shown very clearly that if you look at acetaldehyde in the saliva, you see the red line of these volunteers. If these volunteers gargle with chlorhexidine, their bacterial count is going down, is diminishing, and the result is acetaldehyde demonstrated by the yellow line. So the acetaldehyde concentration in the saliva goes down because of the decrease of bacteria. We have shown that in an animal experiment where germ-free rats were receiving alcohol compared to conventional rats. And the fecal bacteria are, you see this is a logarithmic count here, logarithmic scale here, is much lower, of course, in the germ-free as compared to the conventional. And the acetaldehyde concentration they produce is much lower because you have little bacteria here and a lot of bacteria here. So bacteria produce acetaldehyde from ethanol. There is no questions. I summarize that here. Ethanol metabolizing bacteria exist in the oral cavity, the stomach, and the colon. These bacteria produce high amounts of acetaldehyde. For example, the acetaldehyde concentration in the colon is the highest in the body when calculated per gram of tissue and may exceed 200 micromolar after alcohol consumption. Blood has only 1 to 2 and the liver has also less than that. These high acetaldehyde concentrations are carcinogenic. Now, acetaldehyde not only comes from bacteria, it comes from alcohol dehydrogenase and acetaldehyde dehydrogenase. If the detoxification of acetaldehyde is poor, then we have an accumulation of acetaldehyde. And this is the case in 40% of Asians, Japanese, Chinese, Koreans. They have a gene, an acetaldehyde dehydrogenase 2 gene, which codes only for an enzyme which has only 15% of activity. And you see here again, acetaldehyde has an effect on DNA repair, adduct formation, and DNA methylation. So we have a closer look to these alcohol dehydrogenase deficient individuals. This is a very classical study from Dr. Yokoyama from Tokyo, comparing the ALDH11, these are the Caucasians, these are the normal ones. And the 2-1, the heterozygotes, are those who have only 15% activity. If you look at the odds ratio for these individuals when they drink alcohol. They have, for example, for multiple esophageal cancer, an odds ratio for 54, but also for esophageal cancer and also for upper airway digestive tract cancer in general. So these people, they are really high on risk when they continue to drink alcohol. Actually, it's like a knockout mouse model. Now, individuals with ALDH2-1, these are the heterozygotes, secrete significant more acetaldehyde in their saliva as compared to individuals with ALDH2-1-1. And that's the reason why they have the cancer there. Now, in addition to a diminished detoxification of acetaldehyde, there is also an increased production from ethanol by alcohol dehydrogenase. There are two polymorphisms for the 1B and the 1C. The 1B is not very frequent, the 2 allele is not very frequent in Caucasians, but in Asians. And if you have the 2 allele, you produce 40 times more acetaldehyde. It's very clear that these individuals, they cannot drink at all because the acetaldehyde make them sick. They vomit, they had flush syndromes, so they stop it protective. But the ADH1C, 1 allele, this is frequent 25% in the Caucasian population. Let's have a look on that. You see, the ADH1C, which codes the 1 allele codes for a protein change, the gamma-1 chain, and this enzyme has approximately 2.5 higher maximal velocity to produce acetaldehyde as compared to the gamma-2. The NIH were the first showing that there was an increased risk. If they compared ADH1C11 homozygotes, this is the rapid metabolizing enzyme, with the heterozygotes and with the slow metabolizing enzymes, homozygotes, then you see if they drink little, small amounts of alcohol, there is no difference because not much acetaldehyde is produced. But if they drink a lot, like heavy drinkers do, alcoholics for example, then you have a 40 times higher, a relative risk of 40 compared to 4. So they produce a lot of acetaldehyde and the homozygotes 1-1 produce even more. We measured the acetaldehyde in the saliva of these ADH1-1 homozygotes and they are much higher than compared to the ADH1C12 or 22. And the level of mutagenicity is shown in the red line, that it's very clear that with these alcohol concentration, the acetaldehyde concentration are above mutagenicity. Now we also have studied a number of individuals for the ADH1-1 homozygosity. And this is healthy controls, alcoholic cirrhotics, alcoholic pancreatitis, alcohol dependency, and all alcoholics. And you see that the percentage is about 25% in the population. If this is compared with cancer, with patients who have cancer, this is upper airway digestive tract cancer, hepatocellular cancer, colorectal cancer, all alcoholic cancers, then you see that this percentage doubles. So we have a high risk for cancer development in these individuals. And we went on to look at the colorectal cancer situation with respect to the homozygosity of the ADH1C11 allele. You see when they drink more than 30 grams alcohol per day, there is a significant difference in that proportion. If they drink less than 30 grams, this disappears. That means you need some alcohol, in this case more than 30 grams per day. This is about more than a quarter liter of wine to have an increased risk for cancer when you are homozygote for this allele. Let me summarize the genetics. Acetaldehyde dehydrogenase 2 plays a role in the upper areas digestive tract as shown in the Asians. Alcohol dehydrogenase 1b is not important because it's protective because of the production of high amounts of acetaldehyde. Alcohol dehydrogenase 1c plays a role for upper limb-mediated duct cancer, large intestine, and possibly breast cancer. And I just put down for the liver the PNPLA3, which is a risk factor for cirrhosis, and we know cirrhosis is a risk factor for cancer of the liver. Now let me summarize the evidence for the involvement of acetaldehyde in ethanol-associated cancer. Acetaldehyde is a toxin which binds to proteins, leading to structural and functional alteration of the cell with inhibition of the DNA repair and antioxidative defense system, epigenetic, that means disturbed DNA or histomethylation, and genetic effects. Acetaldehyde forms mutagenic and carcinogenic DNA adducts, especially in hyperregenerative tissues. High acetaldehyde levels occur in the saliva and in the colon following alcohol consumption, and elevated acetaldehyde levels in experimental carcinogenesis accelerates cancer development in the colon. I have not shown you this data. This was studies in our laboratory with rats. Data in humans demonstrate high risk for upper airway digestive tract and colorectal cancer in individuals who accumulate acetaldehyde due to increased detoxification. These are the ALD2 deficient individuals, or increased production, and these are the ADH1C1 homozygotes. Now, let's turn from acetaldehyde to oxidative stress, cytochrome P450, 2E1, and carcinogenesis. And you can see here that, as I pointed out, CYP2E1 is induced by alcohol, and CYP2E1 is responsible for the production of reactive oxygen species, which may bind directly to DNA or which lead to lipid peroxidations, and the products of lipid peroxidation, like 4-hydroxynonenal, bind to DNA. And this is an important generation of etheno-adducts. Also, CYP2E1 is important in the metabolism of certain drugs and xenobiotics, in the activation of procarcinogens. I pointed out already nitrosamines and polycyclic hydrocarbons, and in the degradation of retinol and retinoic acid, and I come to that a little bit later. Now, ethanol induces CYP2E1. You see on the left side, brownish color is the immunohistological determined cytochrome P450 in a heavy drinker with fatty liver. 2 weeks later, after alcohol abstinence, it disappears. How is the dynamic? Is showing here on the upper panel. You see that when volunteers drink 40 grams of alcohol per day, their CYP2E1 measured by the chlorzoxazone test increases already after 1 week, but after 4 weeks it's heavily increased. But not everybody shows this increase, some do not. And when they stop drinking, then within days, these are weeks here, these are days, within days it disappears. After 2 weeks it's gone to normal level, but again some still have that high CYP2E1. And we believe now that those who are highly induced and those who keep their CYP2E1, they have not a good situation with respect to liver disease, but also probably with respect to cancer. Now, reactive oxygen species is on one hand created by inflammation through a cascade via cytokines. That's one point. And alcohol, as I pointed out in the beginning, can lead to alcoholic hepatitis in the liver, to inflammation. But on the other hand, it's also produced through alcohol oxidation by CYP2E1. And CYP2E1 is induced by alcohol, but also by acetone and fatty acids. This is the case in diabetes, and we know that patients with metabolic syndrome and diabetes, they have also CYP2E1 induction. Now, the etheno-adducts after CYP2E1 it's created lipid peroxidation products, trans-4-hydroxynonenal, and this product binds to DNA bases, adenosine, guanosine, cytosine, and it creates these exocyclic etheno-adducts. And this can be presented by immunohistology. On the left side, in alcoholic patients with an enormous load of etheno-adducts in the liver. On the right side, we have a control patients. We can count that. And when we use the HepG2 cells, overexpressing cytochrome P450 2E1 is the lower panel, and we add alcohol in increasing concentration to these cells, with increases brown material representing etheno-adducts. So with increasing alcohol in the overexpressing CYP2E1 cells, there is a lot of adducts compared to the normal CYP2E1 containing cells. And this can be shown here. There is a concentration and time dependency with increased alcohol, increased adducts, with long incubation increased adducts. Now, on the left side, you see the brownish color. These are the adducts. If you give clomethazole, which is a strong, non-competitive inhibitor of CYP2E1, then almost all the adducts are gone. So when we inhibit CYP2E1, we have no adduct formation. The orange columns show the increase in exocyclic etheno-adducts with increasing concentration of alcohol. If clomethazole in a very small concentration is added, there is almost no adduct formation, and with higher concentration there is significantly reduced adduct formation. Then we looked at patients. These are two representative patients, a patient A and a patient B, with high CYP2E1, high 4-hydroxynonenal, and a high load of adducts. And this is a patient with a lower CYP2E1, lower lipid peroxidation product, and lower adducts. And if you look at that in a number of patients, you see there is a very strong and significant correlation between 4-hydroxynonenal and adduct. Here is etheno-desoxyadenosine adduct here shown, or with CYP2E1 and also the same adducts. As more CYP2E1, as more of these carcinogenic adducts you have. From the liver to the esophagus, these are biopsies from patients with esophagus cancer, but the biopsies come adjacent to the tumor from so-called normal tissue. Again, high CYP2E1, intermediate CYP2E1, low CYP2E1, and this goes along with high adduct formation, adenosine adduct, cytosine adduct, and in the low CYP2E1, low adduct formation. And again, the CYP2E1 correlates highly significant with the adduct. Now the question is, CYP2E1 produces ROS, but what happens if we block it ROS with clomethazole? We have shown that in cell cultures, but how is the situation in animal studies? And this is a study we have done with Dr. Wang in Boston. We gave to these animals, to these rat, 20 milligrams of diethylnitro-samine. It's a small amount of a procarcinogen. It's given here, and then there is an adaptation phase, and then the animals received liquid diets, either Liber-Dicali diets, either with alcohol or without alcohol for 10 months, either without or with clomethazole. And these are the results. What we see is already after 10 months, hepatocellular adenoma. I would like to draw your interest on the right side. Your attention on the right side, you see here an adduct formation, adenoma formation in these animals. We also see nodular regenerative hyperplasia. So how is the situation with the animals in general? If you have no alcohol in your diet and just the nitrosamine injection with low or high dose of clomethazole, none of the animals developed adenoma or carcinoma. If you have alcohol and the nitrosamine, 4 out of 5 developed adenomas. And if you have added clomethazole in either low or high dose, none of these animals developed cancer. So obviously the inhibition of CYP2E1 inhibited cancer developed in these animals. Now from the animal study, we now have data in humans, not with cancer, but with respect to liver disease. And I said before, liver disease leads to cirrhosis of the liver, which is prerequisite for cancer development. These are unpublished data, and I want to show you we did a randomized controlled clinical trial where patients with alcohol use disorders went to the ward and were treated for alcohol detoxification, either with chlorazepate, which is a benzo, or with clomethazole, which is an inhibitor of CYP2E1. Both drugs are equally recommended by the German Psychiatric Society. And they were admitted to the hospital and they received the drug for 7 to 10 days and were followed up later on an ambulatory basis. Now what happened is, when we give, look on the right side, when we give the clomethazole, this is admission CYP2E1. After 24 hours, it was almost not measurable when clomethazole was given, and it discharged. It was still very low, almost not measurable. With the chlorazepam, we had no effect on the first day. With the time, it decreases CYP2E1. This is due to the abstinence from alcohol, but still it's quite different from the data with clomethazole. And just one look at the transaminases, and you see the AST on the upper part of the panel and the ALT on the lower part. You see with clomethazole, both enzymes decrease significantly already after 7 to 10 days. Here you see at ALT there was no effect at all, 100 units per liter, whereas under clomethazole it dropped by 50%. So we see that even in humans, obviously the inhibition helps to decrease the injury of that. I summarize here. Alcohol induces CYP2E1, leads to reactive oxygen and nitrogen species, to lipid peroxidation, to lipid peroxidation products, and to DNA damage. And ROS can, of course, also bind directly. Then we have a combination of effects. Acetaldehyde, as I pointed out before, has an effect on the antioxidative defense system. And this, again, plays a role because the ROS cannot be neutralized because the defense system is very poor. And it also has an effect on the DNA repair system. So the DNA damage cannot be repaired because the DNA repair system is very poor. So they play in concert, ROS, CYP2E1, and acetaldehyde. Now, we have further risk factor, folate deficiency. I want to mention that very briefly. These are data from Giovannacci some years ago showing for the colon that the relative risk for distal proximal colon cancer in total is here with low alcohol, high methionine, high folate, 1. And if you have high alcohol, more than 20 grams, this is a quarter of a liter wine per day, with low methionine and with low folate, we have an increase, especially for distal colon cancer, of 7. So folate may play a role. Why? Because folate plays a role with respect to epigenetic factors, with respect to methylation. Normally, methylation takes place when homocysteine is transferred to methionine, and from methionine, S-adenosylmethionine is produced. This is the active methyl donor, and S-adenosylmethionine gives the methyl group to DNA or histones. And this is a very important epigenetic situation. What is alcohol doing? And we know that this effect from homocysteine to methionine needs a methyl group from folate. Alcohol inhibits folate absorption from the intestine, inhibits tetrahydrofolate generation, inhibits the generation of methionine because the enzyme is blocked, inhibits the formation of S-adenosylmethionine because MAT1 enzyme is blocked by alcohol, probably acetaldehyde. This leads to a decrease in phospholipids and neurotransmitters. It also stops the effect of ethanol on the production of glycine from serine because vitamin B6 is decreased by alcohol, and also the homocysteine degradation is blocked because vitamin B6 is needed and also blocked by alcohol. And finally, the methyl transfer to DNA is also blocked by alcohol. So we have multiple steps, multiple effects of alcohol on methyl transfer. And this is probably the reason why folate deficiency plays a role. Now, the next risk is beta-carotene and vitamin A. And this has been shown by Dr. Liebel's laboratory many years ago that alcohol, liver disease, fatty liver, alcoholic hepatitis, and cirrhosis is very low in vitamin A as compared to a normal liver. Vitamin A is low, and we have shown why. When we used microsomes from control and ethanol rats, then we looked with an HPLC analysis on retinol and retinoic acid. This is an HPLC from a normal animal with a peak of retinol and retinoic acid. In the alcohol situation, the retinol is low and the retinoic acid is also very low, almost not measurable. Instead, polar retinol metabolites occur from the metabolism of retinoic acid and retinol. If we have the same and give clomethazole to that, then the whole situation is going back to normal. We block CYP2E1 and the retinol is not metabolized as retinoic acid is also not metabolized. So CYP2E1 obviously is important in the degradation of retinol and retinoic acid. As a result, we have as I show you here, excessive alcohol leads to CYP2E1 induction associated with oxidative stress. I have pointed out that, but also associated with low retinoic acid. This leads to the activation of the junct pathway with C4-C1, AP1 gene is activated. This leads to cell proliferation and to an increased cell proliferation and stimulation of hepatic carcinogenesis. If you're given CYP2E1 inhibitor, then CYP2E1 is low, retinoic acid goes back to normal, and the junct pathway is not activated, and this seems to prevent. But we have a problem because we cannot give vitamin A or retinoic acid supplementation because this, if you give that, because of the induction of CYP2E1, we create polar retinoic metabolites, which are by itself toxic, apoptotic, and possibly carcinogenic. So a supplementation of vitamin A, beta-carotene or retinoic acid in a situation of a heavy drinker is not a good idea. This increases the risk for cancer. Now, estrogen, I come to an end. Estrogen, we know that alcohol increases breast cancer, and one mechanism is possibly alcohol increases estrogen. This experiment shows that when alcohol is given, this is the red line here, down here, in small amounts, about 20 milligrams per 100 ml, which is less than that what is allowed for driving a car in Germany, which is 50 milligrams per 100 ml. Small amounts of alcohol given to premenopausal women increases their estradiol concentrations in the beginning of their menstrual cycle, at the end of the menstrual cycle, but especially at day 11 or 12 in the mid of the menstrual cycle by 30 to 40% when alcohol is present in the blood. Why is this the case? Because alcohol inhibits the degradation of estrogen, it inhibits sulfotransferase and 2-hydroxylase. Alcohol increases the activation of aromatase, which converts testosterone to estrogens, and also alcohol has an effect and stimulatory effect on luteinizing hormone, which has an effect on the ovaries, which produces estrogens, and has an inhibitory effect of melatonin, which inhibit ovaries, which again leads to an increase in estrogen. So estrogens are higher than alcohol, and we know that estrogens are risk factors for breast cancer. Now we come to the final risk factor, precancerous lesions, gastroesophageal reflux disease, colorectal polyps and colitis. Of course, we know that if you have inflammation there and if you have polyps, and alcohol adds the risk to that. But other types of liver disease too. Hepatitis B, C, non-alcoholic fatty liver disease, and hereditary hemochromatosis. I have summarized it here. These are modulators of carcinogenesis, hepatitis B, C, and the others. So let's have a look at hepatitis B. These are studies from China and from Japan, and we see if you have alcohol more than 3 per day and over a long period of time, 15 years, and here a quarter of liter wine. In any case, you have an increased risk for cancer development in the liver. Hepatitis B is a DNA virus which integrates in the liver, and I have seen several patients 40 years after infection coming to cancer of the liver, even not with full-blown cirrhosis. Now, hepatitis C is more difficult and is probably more sensitive. This is a study from Italy showing that if you drink 40 to 80 grams or more than 80 grams, which is a lot, there is an increased odds ratio if you drink a lot of alcohol, 7 in these patients with hepatitis C. And the study from US says no or yes, if you drink alcohol, you have a 2.4 increased risk for cancer. But Swedish studies have shown that even small amounts of alcohol are not good for the liver, increasing fibrosis, leading to cirrhosis, and may by this have an increased risk for cancer. Now, with respect to non-alcoholic steatohepatitis, it was, I think, 10 years ago when it was recommended small amounts of alcohol to decrease the peripheral insulin resistance. Now, we now know that probably alcohol is not very good when people with NASH or non-alcoholic fatty liver disease drink it. You see here the study by Asha showing any alcohol consumption has a hazard ratio, not with 3.6 is even higher than body mass index for cancer. And if you look at the curve, you see even social drinking increases the risk for hepatocellular cancer in NASH patients over time compared to never drinkers. So this was a long-time recommendation by Dr. Liangpun Sakal and Dr. Shalasani, ending the article by stating, until further data from rigorous prospective studies become available, people with NAFLD should avoid alcohol of any type or amount. And we have some years later summarized that, summarized the data and stated that subjects with NASH should abstain from alcohol at any time. And now in 2021, it's very clear that patients with NASH should not drink alcohol. Now I have a case report at the end, a case which I have seen some years ago, a 65-year-old patient. He was laparoscoped in 1981 with a diagnosis at that time with non-A, non-B hepatitis, which was of course hepatitis C with mild fibrosis. In long time later, 2005, he had elevated serum transaminases between 100 and 200. He had a diabetes with an HbA1c of 9.2, not very well monitored, and he also consumed a quarter of a liter of wine every day. He had a biopsy in 2005. The biopsy is shown here. It shows ballooning in fatty hepatocytes, Mallory bodies not only peripherally for NASH, but also centrally for ASH, for alcohol steatohepatitis. Signs of endogenous and exogenous toxic damage. And we also see round cell infiltrates by lymphocytes. This is typical for hepatitis C. So we have various stigmas in the histology for NASH, for alcohol, and for hepatitis C, and he indeed developed full-blown cirrhosis, but not only cirrhosis. 6 years later, he developed hepatocellular cancer, these patients. Meanwhile, he died. So we had 3 diseases in one patient, and that's what we see more frequently in this case, non-alcoholic fatty liver disease, alcoholic liver disease, and hepatitis C. Specific mechanism I have summarized at the end here for ethanol-mediated carcinogenesis. I discussed acetaldehyde with the oxidative stress, with the reactive oxygen species. Iron, did not have much time on iron, but of course hemochromatosis is a risk factor. The liver is full of iron, and the iron contributes to ROS. Cytochrome P452-1, I talked about retinoids, epigenetics, cancer genes and signal pathways. There are some which are affected by alcohol. Inflammation, as in immune suppression, is probably important when metastases occur. There are some data showing that colon cancer metastases to the liver occur more frequently when alcohol is consumed. And organ-specific effect, I said cirrhosis is a prerequisite. People with gastroesophageal reflux disease, of course, are also higher on risk. If you summarize, you see alcohol increases CYP2E1, which lead to the activation of procarcinogen, especially in tobacco smoke, but also in nutrients, to carcinogens, which act on a healthy cell. Alcohol leads to ROS and RNS, reactive nitrogen species, which initiate cancer in ROS. And of course, the carcinogens, they may be easily uptaken, while ethanol is a solvent. Now, alcohol leads to acetaldehyde, which binds to DNA, plays a role in initiation, but also plays a role in promotion with many effects. I also said with damaging effect on the mucosa, injuring mucosa, injuring enzymes, protein binding, and so on. And we have altered methylation, DNA hypomethylation as a contributing factor in promotion. We have hyperproliferation again in promotion, and the tumor cells to metastasis, we have immune suppression. And of course, special organs, special target organs have special mechanism, estrogens in breast cancer, cirrhosis for the liver in hepatocellular cancer, and gastroesophageal disease in esophageal cancer. I summarize. Chronic alcohol consumption is a risk factor for cancer of the upper aerodigestive tract, the liver, the colorectum, and the female breast. Factors which modify the carcinogenic effect of ethanol are smoking, poor oral hygiene, genetics, folate deficiency or additional intake of beta-carotene or vitamin A, estrogens, and pre-existing diseases, gastroesophageal reflux disease, colorectal polyps, colitis, and various liver diseases. Ethanol-mediated carcinogenic mechanisms include acetaldehyde and reactive oxygen species primarily generated through inflammation in cytochrome P450 associated with DNA lesions. And ethanol-mediated hepatic cancer occurs predominantly in a cirrhotic liver. As a consequence, individuals with chronic ethanol consumption, more than 30 grams a day, should be checked regularly for liver disease and cancer by fibroscan, endoscopy, ENT monitoring, and precautionary gynecologic checkups. And gynecologists should ask for alcohol consumption in their patients. Thank you very much for your attention.